So good afternoon, everyone. My name is Joe Gallagher. I'm a GP in Gorey in County Wexford. And this morning I'll tell you about our emerging partnership, which is in Tony's neonatal resuscitation programme at the moment, of developing a partnership between our surgery and the Department of Internal Medicine in Mzuzu Central Hospital in northern Malawi. I hope to give you an overview of how this partnership has evolved, where we are at the moment, and our plans for the future. And of course, what we're really hoping is that you'll tell us where to go next. So it all started, I worked in Malawi in 2009, and while there I met this man, John Ryan, who's a priest who's been in Malawi for over 30 years, but also is a professor of mathematics in Mzuzu. And his expertise is in GOPA codes, and I'm sure most of you know what they are. I didn't at the time, but they're cryptography. So Hillary Clinton will be very interested in this. This is what's used to encrypt your emails. And John invited me up to Mzuzu when I was there, and I never made it. When I came back to Gorey, to the very exotically named PAM surgery, we developed some small projects with the hospital and the people there around child health and primary care, but they were relatively informal. And of course, it was the name that attracted me to the PAM's GP surgery, with images of the beach and palm trees. Unfortunately, it was a bit of false advertising, because that's the palm tree there, hidden in behind the extension. And the surgery, it's a 7 GP surgery. We have 1 GP trainee as well. We have 5 nurses and 10 administration staff. And we tend to see around 70,000 patients a year. And so it may seem a bit unusual to twin a GP surgery with Mzuzu Central Hospital, because Mzuzu Central Hospital, one thing I forgot to mention is, one of the things I did discover when we were there is that the staff actually come from and have worked in a variety of areas around the world. And this is a map we have actually in our reception, just showing these are places where all our staff have worked. And there's a real sense of trying to bring that together and perhaps build on that. We'd all done this sort of independently, and in the nature of life, things move on and you get busy. But we felt that there was a value to try and bring that together and perhaps work together to try and form a partnership with an institution. And so because of the preliminary work we've been doing with Mzuzu, and particularly Mzuzu Central Hospital, we decided this may be a place for us to come together. And from our preliminary discussions, one of the major challenges that they faced was around non-communicable diseases. And in essence, Mzuzu Central Hospital serves as a primary care facility for non-communicable diseases in the region. And that's how we sort of came together around that. So although it may be sort of surprising that non-communicable diseases such as diabetes or hypertension or asthma are traditionally seen as problems of high-income countries, but they are a burgeoning problem across the world, as evidenced by the appointment of Michael Bloomberg as a UN ambassador for non-communicable diseases just last month. The rates of diabetes and hypertension and asthma in Malawi are now almost the same as what they are in Ireland. And yet the health system is more structured around acute care, and even at the moment is overwhelmed with that acute care. We're coming into the pneumonia and malaria season now at the moment, and the system is based on episodic, seeing the patients, sending them home. And in terms of managing chronic conditions and trying to have continuous follow-up, this was a challenge that they faced, and how they can alter and adapt their system to that sort of a process. So we'd had discussions by Skype, we'd had emails, we'd talked a lot about various ideas, but really it's about meeting face-to-face. And thanks to ESTHER Ireland, we really had the opportunity through the startup grant for us to actually sit down and try and formalise the partnership and decide what would be the next steps. And rather than sort of continue with small pilot projects and discussing ideas, to actually plan what to do. So our initial plan was that we would go to Malawi, we'd meet with Mzuzu Central Hospital and the various staff there. But like all things, we quickly realised that really we needed to expand beyond that in our discussions, because the policy shift in Malawi is towards moving non-communicable disease care to the district hospitals and then on to the community. And so therefore, to develop this collaboration, which at the moment, how the system is structured with a hospital-based system, really we need to involve the other groups. And it sort of became a bit like an Irish wedding when we went out there for the week. Everyone came along, and we got a huge amount of buy-in from all sorts of groups, from Ungwero, which is a community-based group involved in community healthcare education, right up to the Ministry of Health in Malawi, who very interestingly had just been involved in establishing a family medicine programme. The first 3 doctors are going through that at the moment, and we had very fruitful discussions with the family medicine programme in Malawi around their views about how things develop, and they really see non-communicable disease as being something that family medicine will take on in Malawi, along with the clinical officers and nurses and working with them. We also had academic partners in Ireland and in Belfast. The South East GP training programme also has a lot of interest and has a trainee who goes out to Malawi every year as well. So we had a lot of groups, and it was very fruitful to sort of learn the different perspectives, and particularly, as I mentioned, as planning this transition from hospital-based care to community-based care, to involve all these groups in trying to plan how the partnership might work to help enable that and develop structures. But of course, one of the problems is, like any wedding, you can get arguments if you start bringing everyone together, and the family can get a bit upset. So we sort of had to try and figure out, well, how can we make this partnership work? And really through discussions with Nadine and David, we really came with this sort of approaches so that we would still maintain that partnership between the PAMS GP surgery and the internal medicine department in the Mzuzu Central Hospital, but form an advisory group of all the other people around us who would be involved in the projects and developing those projects and would give input, and perhaps in time may become more closely involved, but at these initial stages that we would continue to build on the relationships that we've built in the Mzuzu Central Hospital and involve the other groups through an advisory group. We set ourselves some goals, and this is where we're at the moment. We have some 12-month goals and 36-month goals. We felt that having some initial projects that we would work together on, such as flow sheets and decision aids for non-communicable diseases, and you saw in the video at the beginning, Peter talking about the stamp that was used in the Carter Bay Hospital, developing those and making them part of the standard work practices of people, maybe something that's useful and can build confidence on both sides. The use of modern technology, 3G is every place in Malawi. You can't get electricity, but you can get a 3G signal. In actual fact, on our Skype calls, it's the Irish connection that drops all the time. Or at least the Gory connection, I shouldn't be, that's not fair. But WhatsApp as instant communication, transmission of images, phone calls, Skype obviously for video sessions can be very useful as well. And facilitates learning between both groups. One of the areas that was really felt useful would be to develop a clinical fellow in non-communicable diseases, to allow people from Malawi to come to Ireland and learn about how maybe perhaps chronic care might be structured here, and then to travel back to Malawi and have protected time to serve as an education and research resource there. And that's something that we're sort of working to develop. And we would see this as not necessarily being a doctor, maybe a clinical officer, or maybe a nurse, or maybe one of the family medicine graduates, depending on the needs of the area. Initially, this was also seen as being a capacity-building initiative, particularly for the smaller district hospitals, which find it difficult to attract staff and recruit them, and if by sort of enabling this sort of a structure, it may be seen as something that would attract and retain staff in perhaps some of the more rural and remote areas. Like many people here, we're trying to see how can we fund that fellowship, which is relatively low cost, but still often requires some money to get it going. And we're trying to develop a memorandum of understanding to formalise that partnership between ourselves and the Mzuzu Central Hospital, and forming the advisory group involving our Malawi and Irish representatives. I suppose in the medium term, we'd like to develop some more e-health and electronic resources, particularly developing a bit like the RCSI on the existing resources that are available, and expand the partnership, as I said, to some of the other maybe more outlying healthcare facilities in the northern region, and involve the family medicine programme with the local Irish GP training programmes as well. And there's certainly been a lot of interest initially in that, and developing partnerships where exchanges could take place between both programmes. And to have a structured and continuous NCD clinical fellow role who's rotating through Ireland and then returning to Malawi to continue to develop the programmes in the region they're in, and having dedicated time to do that. What did we learn? I suppose one of the things we learned is that it's very good to formalise the partnership. It's great to have conversations, and they're saying to have that sort of one-on-one with your colleagues in Malawi. But in order for it to be sustainable and for it to grow, it really needs to sort of people sit down and decide this is how we need to grow these things. It's important to involve all colleagues. The point was made earlier about involving administration staff. Our staff in our surgery have really been enthusiastic about this, and they know best about how to structure the processes, how to develop the clinics, how to develop the recall systems, much better than what we do. And by involving them, we've really sort of brought the real enthusiasm in the surgery to it, and also they can work with their colleagues in Malawi around that. As we mentioned, it's important to consult widely, particularly in an area like non-communicable diseases, where things are changing and the focus of care is changing and the place of care is changing. But it's also important to stay focused so that we don't start to try and achieve everything all in one go. We felt it was important to build in existing processes. So although chronic care or non-communicable disease care is relatively new in essence in Malawi, processes such as HIV and TB care essentially have the same structure of continuous follow-up and recall. And so we're working to sort of try and build on those processes rather than create new ones. And I think it's important as well that we start with small projects so that we can build that trust and find where barriers may occur between the groups and try and resolve those before leading on to bigger plans. That's an important point we learned as a surgery is important as well. We've had Dr. Beatrice Magwamba, who's the Director of Non-Communicable Disease in Malawi, come to our surgery. She really led us to examine our own protocols. Why are we doing things this way? Why do we, do these blood tests so often? Why do these staff do these things? They're all things that are important for us to look at. Group education is something that is very common in Malawi. There's another way to do it. There's a real focus on individual education. But group education is there, so we're developing some programs around diabetes education in Gori. And obviously the exchange visits staff to Ireland and Malawi have invigorated people in terms of their interest in healthcare and in culture and developing processes and looking at new processes both in Malawi but also in our own surgery. I think an important aspect as well is to raise our cultural awareness, not just among our staff and among patients who have come from other countries to our surgery, but even the impact on culture in general on healthcare and how it's heightened our awareness that even within our own country that really culture trumps everything, not to mention Trump. And finally, we want to thank ESTHER Ireland not only for the startup grant, which really allowed us to go and meet people and really have these fantastic discussions, but also for their advice in developing the partnership and the structures of it. And in particular, our colleagues in Malawi and Ireland who really enthusiastically supported the development of the partnership, covered for us, taking phone calls at all odd hours, and helped us along the way. So thank you.